Uh, hey everyone. Today I'm happy to introduce for our community Effie, and Effie is a physician, doctor, professional, and Effie, thank you so much for this opportunity. Feel free to introduce yourself. Probably I miss some of your titles. Sorry if if I missed something. Yeah.
No, you're fine. Hi, Alex. Thank you so much for inviting me today to chat with you guys. I feel so honored and so happy. My name is Effie Andrekopoulou, and I'm a cardiologist living and practicing in the US. I'm in Birmingham, Alabama. I'm in the South. And I'm an assistant professor at UAB, affiliated with cardiology and radiology. My background is both in cardiology and cardiovascular imaging. And I'm also so relieved and happy to say that I'm an MBA student. I'm currently in my final semester, finishing up. And my passion is in healthcare delivery and incorporating digital solutions to optimize delivery of care to our patients. And at the same time, help with physician burnout and make our lives easier along the journey as well.
Great. Thank you so much for this introduction. And actually, I am going to split our interview on the 3 parts. First, we will talk about your background. Secondary, we will talk about your general vision on heart attack problem. And at the end, probably we will talk about COVID, technology, things which related to the heart disease, heart attack, and all other things. Okay?
Yeah.
And my first question is, how did you choose the medicine area? What was, why you choose this area, and what was the point, your personal point?
So my path in medicine is different from most US physicians' path, because I was born and raised in Athens in Greece. And in Greece, students have to make their choice of what kind of university, school, or higher academic education they want to pursue, but they're asked to do that at a much younger age compared to the US. So we're asked to do that when we're 17 and a half, 18 years old. So I was 17 years old when I made the choice to go into med school in Athens. And I have to be 100% honest, I did not know what I was getting myself into at the time, because I don't come from a family of physicians. My family are blue-collar workers, without any advanced higher academic education. And so I had no idea what I was going into, but thankfully, thank God, I really loved medicine. I loved med school. I had great mentors in med school, and one of my mentors was the one in med school in Athens, was the one who urged me to do my training and residency and fellowship in the US.
Wow.
So how I ended up going into med school. I have to admit, I didn't have a lot of insight when I first made that decision, but I do not regret having made that decision at such a young age.
Great. Could you share a little bit more details about National Kapodistrian University of Athens, how the life in this school campus and all things related to this time? And why did you choose this university? I'm sure that you have some choices, right?
Yes. There's, I want to say there are 6 med schools in Greece. And just for reference, the Greek population is about 11 million. The way we enter med school is again different from the US way. So the biggest criterion for entry into med school in Greece is how students do at their finals. In their final year of high school, we all sit the same exams across the country. And depending on how we do, we get ranked
and our selections, our ranking for our schools gets ranked, and everything kind of like goes into the same system, and then it spits out who goes where.
Oh, got it.
Yes.
Okay.
And Athens, as far as Athens is concerned, and why I chose the med school in Athens was my #1 choice. And I got in. A couple of reasons. #1 was convenience, because I was born and raised in Athens, and so I wouldn't have to move outside of home. And because it is the most prestigious med school in the country. And I knew I would get very good training.
I got it. You mentioned that you was born in Athens, and it was your like obvious choice, right, to join this university. And I know that in California there is some rule when you want to make your PhD, you should go outside your alma mater university. In other words, it's very obvious situation when the guys from the Caltech, they go to the Europe and make the PhD, and after that back. You mentioned about your great achievements in your current university, and after that you started join Harvard University. Could you share this incredible story and how it's possible?
Yeah, so so my journey in the US has been all over the place. Harvard has been my last stop in my training, and second to last stop in my career. But my journey in the US, and I can expand in any of those, however you like me to. But after I graduated med school, actually, when I was in my last year of med school in Athens, I came as a visiting medical student in the US, and I was accepted at Johns Hopkins in Baltimore.
Oh, yeah.
This is me having never left home ever before in my life. And so I flew across the continent, I flew across the Atlantic, and I made it all the way to Baltimore. And I fell in love with Hopkins. It was an amazing experience. It really changed the way I was thinking about my future at the time and about what I would want to do in my life at the time. And that's when I really solidified my decision to pursue training, residency, fellowship training in the US. Once I went to Hopkins, from day one, I knew I did not want to go back to Greece or Europe. I spent a year and a half at Hopkins, first as a visiting student, and then I did a research fellowship with the Department of Surgery and the Division of Cardiology combined. And immediately after that year and a half was over, I started my residency in internal medicine in Philadelphia at Thomas Jefferson University, where once again, my experience was amazing. I got great training and I made great friends. I love Philadelphia. Following Philadelphia, where I spent 3 years of internal medicine, I came to Birmingham for another 3 years of general cardiology fellowship training. And following that, I went to Boston, to Harvard, for 2 years of training in advanced cardiovascular imaging. And then I came back to Birmingham, to University of Alabama, where I got my first job as an attending physician.
Amazing journey. It sounds like an adventure, incredible adventure.
Yeah.
My next question about medical system, on your personal opinion, what the difference between United States and Greece, if it's possible to compare from your point of view? Yeah.
Sure. Yes. No, that's a very good question. So first of all, before we even jump into comparisons, a few important things to make clear is that, like I said, Greece is an 11 million people country
versus the US.
Yeah.
And the financial situation, like financially, Greece is not where the US is.
Oh, yeah.
In terms of resources and in terms of research. the amount of research that happens in the US obviously cannot be compared at all to the amount of research that happens in Greece. And the type of training in the US, for those reasons, because there's so many more resources, the training in the US is much better structured compared to training in Greece.
Mm-hmm.
Not that Greece doesn't make great physicians, they absolutely do, and I have a tremendous respect and appreciation and admiration for what my Greek colleagues do in Greece. I don't know if I would be able to do what they're doing in Greece, I'm gonna be honest. But I would have to acknowledge and appreciate the fact that training and the curriculum in the US medical training is much better structured. Every single, as a resident and as a fellow, every single month, we know exactly what rotation we have to be in. We know exactly what is expected from us. We know what we have to read up on and how to prepare. And this happens for every single month for all of my 8 years of training as a resident and then as a fellow. In Greece, it's a little bit more, there is some structure to the curriculum, but there's an appreciable component of the trainee having to actively pursue their training.
I got it. Thank you. And to finish our first part about your background, you mentioned about MBA. Could you share, because medicine and cardiology, this is a one world, and business and all stuff related to this is another world, and how this help you to fulfill your ambitions and how this help for your career. Could you share some words about your MBA? Yeah.
Yes, absolutely. So as I mentioned earlier, I was only 17 when I was asked to make the decision of what school I wanted to go into, what kind of university I wanted to go into. So I was not an adult yet, being 17 years old. Pursuing MBA, my MBA degree has been the first educational decision that I made for myself as an adult, as a full-grown adult. And I couldn't be happier. I have not regretted it one bit. I know it's been challenging in terms of time constraints because I am a full-time physician and pursuing my MBA. But it opened up a different world to me that I had no idea existed. And I feel like it's one of my endeavors that has contributed the most to my both personal and professional growth. Why I decided I wanted to go into an MBA degree was because I wanted to, the reason why I entered was because I wanted to understand better what makes people behave the way they do.
Interesting approach. Yeah.
Both for my patients, both from a physician perspective, but also from a person perspective. Makes people behave the way they do. What pushes people? What pushes people to make one decision versus another? And that's why I love behavioral economics, and I love healthcare marketing too, because they dive into those concepts. And what I'm hoping I can do, having both an MD and an MBA degree, is I want to use them as a way to build my career path along a hybrid model of a clinician administrator or clinician at the intersection of healthcare, care delivery, and digital solutions, which my MD degree in and of itself wouldn't be able to prepare me, and my clinical experience in and of itself wouldn't prepare me as well.
Cool. And actually, this is a very smart move because, great things happens. Usually they happens in crossing area, when they cross into absolutely different subjects, and this magic happens in that moment. Wonderful. It's amazing. Okay, and let's start our second part, and this will be more about heart attack problem. And my first question: why do you mentioned about behavioral economics, and I'm sure that you have some insights on this. Why do so many people have problems with a heart attack? Medical universities, institutes, government, money, all countries, a lot of resources working to decrease heart attack. Anyway, every year we have this problem, and it seems that for the future we will still have this problem, and probably we will the amount of the people with the heart disease will increase. What do you think? Why?
Yeah, well, that's the million-dollar question. If once we're able to fully answer this question and understand all the different components that play
into people getting heart attacks or heart disease in general, heart failure, heart attacks, hypertension, high cholesterol. I'm also going to put diabetes in there because it's all
exactly, yeah,
metabolic spectrum of disease. So I don't think we have enough time to discuss fully about this, but I will tell you how I think about it in my head, because I like thinking in boxes. So I think of three main issues that play a part in that. One issue is patient-related factors. And that someone is overweight, someone is a smoker, someone has diabetes, which could be either hereditary, people are born with that, or it could be acquired because people don't exercise as frequently, they don't eat healthy. And that's what we call comorbidities, is what other kind of diseases do you have that make you more prone and more likely to get a heart attack. So things like we said, smoking, high blood pressure, high cholesterol, not eating healthy, not being active, not exercising. So those are patient-related factors. Another important thing is people with cancer. There's chemotherapy medications or radiation treatment that people could have gotten as kids, where, it's not really, I'm going to use something that people shouldn't say, but it's not really their fault. They didn't choose necessarily to get that chemotherapy medication or to get radiation treatment as kids. They needed it to survive their cancer.
Yeah.
But we know that these do affect the heart vessels and do make people more at risk of getting a heart attack later on in life. So those are the patient-related factors. Then there's the healthcare system, the systematic factors. And those have to do with the things that I think are going to be the toughest ever to be addressed. Those have to do with biases that we in the healthcare community as physicians and providers and the system, the biases that are inherent to our system with respect to both diagnosing and managing heart disease. And that has to do with, that will be the hardest one to address, because we would first have to understand our own setbacks and our own biases, so that we are able to then say, okay, what have I been doing wrong? Not because I want to, but because systematically, this is how the system is wired for me to function as a provider, even as a patient, or even as a patient. And with respect to the patient, these factors, these biases are also related to the socioeconomic and social determinants of health and social determinants of culture factors that come into play. So, and that's something that I'm also very passionate about, is trying to understand how we can create the 360-degree view of our communities that will allow us to identify these patients who are most at risk. And one thing that we haven't been doing a great job at for the past several decades of medicine, but now we are identifying and recognizing the importance even more, is the importance of our zip codes.
Mm-hmm.
We know that our zip codes can kill us. There's zip codes where people are more likely to be smokers. They have lower incomes. They have lower insurance coverage. They don't have education that would allow them to have the kind of healthcare literacy that they would need to appreciate the risks that they're at and what needs to be done. And that's not the fault of the patient or the doctor. That goes back to the system and how our communities are systematically built to allow for this kind of disparities in access to care and disparities in healthcare literacy that fuel those diseases even more.
In other words, this concept of the zip code is kind of cultural thing, right? When you're from childhood, you have some kind of cautions and uncautions of the problem. And sometimes people don't associate some actions which necessary or will be necessary to do right now to prevent heart disease in 10 years, in 20 years. They don't know this, they get this risk, and after that they have results according to these risks, right?
Exactly. Yes.
Got it.
Exactly right. Yeah.
Okay, and my next question about the difference for this heart attack problem in Greece and United States. If you're aware about Greece, if it's possible. I'm sure that you're every time involved in comparison these things. What are your thoughts?
A couple of things. The heart disease is as big of an issue in Greece as it is in the US. There's no question about that, sadly. Obviously, the absolute numbers are lower because, again, we're only 11 million people in Greece, as opposed to hundreds of millions in the US. But the same factors come into play. The same factors with respect to smoking. Greece has a huge problem with smoking. I think Greece is one of the highest percentages of smokers in the world. Yeah, smoking is a big thing in Greece. Obesity is getting a big problem in Greece as well, like it is in the US. And that's because people have to rely more on delivery, takeout, fast food, because there's not enough time to cook fresh at home. It gets tougher and tougher, and it also gets more expensive and pricier to be able to afford fresh produce, which is another important obstacle. The one thing in Greece that's different from the US is the insurance system.
Oh, it's very interesting.
Yes. So in Greece, everyone is insured. There's no such thing as people having to pay for their insurance. Everyone is insured in Greece. But uninsurance is becoming a bigger problem for now, the past decade or so. And that is linked to the financial austerity measures and the economic crisis in Greece. Which is an interesting point to make, is that as much as we don't like to admit or think about it, healthcare is very tightly linked to the economy.
Yeah, social behavioral economics. It's
exactly.
impossible don't have this connection point between this.
Yes, healthcare is very closely linked to the economy. If the economy does well, people can afford for their health, and they can afford to go to the doctor, they can afford to buy their medications, they can afford to have screening tests for prevention. But that means that people have enough money first to make sure that they can survive, and they have food on their table and they have a roof over their head. If people have if we don't have these problems solved first, we are not going to focus on our health.
Got it.
As cynical as it may sound, as raw as it may sound, it's the truth. Just the needs. It's just a need. It's a bigger need to survive and make sure that there's food on the table and you have a bed to lay on at night, versus going to your doctor for your annual checkup.
Yeah, in other words, if you have cheap pizza or burrito, whatever, and you don't have a lot of money or time to thinking about fresh food, salads, or whatever which related
Exactly.
to that. First of all, you should to survive in this world, and after then you probably will think about situation. And one more point, that in terms of insurance, that there are two cases, right? In the United States, you have a very good quality of the medicine and other things, but this level of medicine available only for the people who have a good insurance. It's a one situation. In other words, there are a lot of people who don't have this insurance. And in Greece, another situation, everyone has insurance, everyone, but the quality of the service to provide everyone service, it's not so easy to provide very good quality for each of the personnel in Greece.
Yes.
Thank you for this explanation.
Greece is closer to the Canadian
insurance model.
Oh, many Americans have a medical trip to the Canada to have a surgery, to have another treatment.
Yeah.
And the reason why, because it's very expensive. Includes for the very rich guy. They don't want to spend all this money through the insurance system, through the healthcare system of the United States. Thank you. And my next question will be about COVID. And I'm sure that you see this whole situation. How does COVID influence heart failure and heart disease, not only heart attack?
Yeah. What we have been seeing is that COVID definitely has an effect on the heart, both the myocardium and the endothelium, the lining of the blood vessels, and it definitely increases the risk of heart attacks, of myocarditis, pericarditis, and high blood pressure. I've had patients come to my clinic who never had problems with high blood pressure. And after getting COVID, they started suffering high blood pressure. We don't have a good explanation what exactly is the underlying mechanism and etiology that drives these changes. Again, though, we do know that the virus affects the endothelium and the myocardium. So that's one of the things that we're seeing with COVID. The other thing that we're seeing with COVID is that people are just not the way they used to be. After they get COVID, especially those who get long COVID syndrome, and they have symptoms long after the initial viral insult, we see them that they feel very tired, very weak. And even people who used to exercise and be healthy prior to COVID and not have any issues. I remember one of my patients who was a young 40-year-old woman, very active pre-COVID. Biking, mountain biking, jogging and running. And after COVID, it took her more than 9 months to be able to take her dog around the block without feeling like she couldn't make it.
Yeah, it's very dramatic change in life of the people. Yeah, because before COVID, you are active, you have a life, you have a friends, communication, activities, and after your achievement of the one round with the dog around the block.
It is. So not only does it increase the risk of endothelial dysfunction and thrombosis, which in and of themselves increase the risk of heart attacks, not only does it cause could it cause high blood pressure, not always, but it could. But then on top of that, you get the
inactivity that comes with it because people are so weak and tired all the time. And it's the perfect storm for making heart disease even more prevalent.
Got it. Okay, and try to imagine that you have financial resources, human resources. You have a genius team of the scientists, physicians, professors. You have everything. And what will be your silver bullet to exclude everyone from heart attack risk score? In a few words, if it's possible. I'm sure that this is a very...
It's possible, okay.
Yeah.
If it's possible, I think I would target the
disparities that are driven by our socioeconomic factors. So I would, if I could have like a magic wand and change one thing, I would try to solve all the socioeconomic factors that drive disparities in access to care. That would be my number one thing that I would do. In terms of making sure that people have access to cheap and fresh produce, they have access to their doctor's appointment, they have access to tests, meaning access both in terms of transportation and financially. That's what I would do, but I would really hone into healthcare literacy as well, which is also part of that. This is all related to your zip code, to where you live, and resources you have. So if I could magically do one thing, I would eliminate the socioeconomically driven disparities. That would be one thing. And
another thing,
yeah. If I can add one thing, this also has to do, it's also something that COVID is highlighting, is that we also need to have equity in terms of our digital access and health literacy. Because I love the fact that COVID has made things more flexible from a digital perspective in terms of telehealth and access to telemedicine visits. But what we don't want to happen is for those healthcare disparities to extend into digital healthcare disparities and have people who live in areas without good Wi-Fi, or people, because of their poor socioeconomic status, they may not have access to a phone or an app or internet, or they may have a phone, but they don't know how to use it. Or because they have to work 3 jobs just to make ends meet, they don't have time to make it to a telehealth visit. So I think that's very, very important to make sure that we do this one right, and we don't allow for the chasm to deepen because of digital disparities in access to care.
Yeah, it's a very interesting point which you touch: telemedicine, telehealth, and digital thing. What do you think in the future? What the place of technology will be for heart attack risk?
Yeah, what I'm hoping and what we are working on at UAB, what I'm hoping is that AI and technology will allow us to integrate all of the clinical and socioeconomic and demographic and genomics data of our patients into a simple model that would allow us to risk stratify our patients and be able to predict their risk. And because we're able to predict their risk, we can prescribe treatment even earlier. That would be one thing, but the way this should be done is making sure we don't put more burden on the doctors.
Yeah, I got it.
We should use AI to make our lives easier and to allow us for more time to connect with our patients on a personal level, because we will have AI. All we would have to do is just talk to our patient, collect the right information, and then I'm using very simple terminology, but feed it into the model, and then we would know how to take care of our patient. And not only that, we would do that at a much earlier stage to be able to keep them from developing heart disease, whatever that might be. So would we have time to connect with our patients so that our patients don't feel like their doctor is looking at the screen instead of looking at them when they talk?
Oh, yeah. This is a big problem.
Yeah. So hopefully it would take us back to the very, very fundamentals of being a doctor, meaning talking to your patient, listening to what your patient is telling you without being stressed out about having to do the note, then put everything together, and then have to fill out paperwork, and then have to make phone calls, and then have to put in orders, and then have to get back to the patient to tell them what the final plan is. So hopefully AI to make our lives easier, but also by making our lives easier, we're going to be able to take better care of our patients.
Effie, thank you so much for all your insight, and actually we're on time. It was a lot of interesting ideas, and I like your solution, and I like your vision on the problem. And thank you for your insight about COVID, how it was and what will be in the future. Thank you for these opportunities. I'm sure that all our volunteers, regular people, and maybe business and companies who will watch this video will be inspired by your vision, and thank you. And I wish you all the best in your career journey and your next steps. I'm sure that you will achieve great success in all areas which you touch. Thank you so much, Effie.
Thank you so much, Alex. And anyone, feel free to reach out to me via LinkedIn. Alex, you can go ahead and share my LinkedIn, however you
okay.
Yeah.
I will add it to the description. Effie, thank you so much.
I appreciate it. Thank you.
Yeah. See you next time.
See you. Bye.
Bye-bye.